Hello everyone again. We're very sorry we were having a bit of technical issues, and now I can see our speaker is here. Please welcome Dr. Panayotis Vlachosterios, who is an assistant professor of clinical medicine at Renal Medical University in New York and is a consultant medical oncologist at ISO and Thessalis Medical Center in Greece. And we'll be speaking about biomarkers for adjuvant therapy and benefit RCC. Dr. Panayotis, may we kindly ask to share your presentation?
I think I am. Can you see it? Can you see it, please?
Thank you.
Okay. Is it full screen?
Can you please put in the presenter mode your presentation?
Yes, of course. Is this better now? Is it okay? Okay. Shall we start? Can you hear me?
Yes, we can hear you very well, and we're ready to start.
Okay, great. Thank you so much. Thanks to the organizers, OncoDaily, and to the chairs of this very interesting, one-of-its-kind global meeting on very interesting topics in renal oncology for inviting me to give this presentation. My topic is biomarkers for adjuvant therapy benefit in renal cell carcinoma. It's really a very intriguing area of ongoing investigation, actually. These are my disclosures. I would like to start from setting the stage regarding the landscape of adjuvant treatments that we had for many years ago. There were several trials in the TKI setting. Essentially, you can see a very detailed table, including most important clinical trials using angiogenesis inhibitors like sunitinib, sorafenib, and also mTOR inhibitors. Essentially, the main takeaway from this table is that the majority of the trials, actually all the trials, were negative. So overall lack of efficacy, there was significant toxicity, and there was only a slight benefit from a higher dose in some cases at the price of worse toxicity. For example, in the case of PROTECT trial, whereby DFS was superior with a higher dose of pazopanib. However, the side effects were also greater. Moving on to the immune checkpoint inhibitor adjuvant setting, this is a comprehensive table including to date all phase 3 trials that have been conducted and some that are ongoing, like Rampart, that tried to assess whether there is a benefit of adjuvant immunotherapy in patients with resected renal cell carcinoma. The majority of the trials included just clear cell patients. The PROSPER trial included and the Rampart trial are including all histologies. Essentially, what you can tease out from this table is that the highlighted in red is that the Keynote 564 trial, which we're going to talk a little bit more about in the next few slides, was the only positive one, both with respect to disease-free survival and overall survival. This is also highlighted here. All the other trials, adjuvant atezo, EP-nivo, preoperative nivo, were negative. And there are also 2 ongoing trials, Rampart and LightSpark. These are the Kaplan-Meier curves from Keynote 564 trial with a positive benefit of adjuvant pembrolizumab, both in disease-free survival. You can see the hazard ratio is 0.72. And in terms of overall survival, more recent publication, New England Journal of Medicine by Dr. Chouiri in 2024. And here are the pre-specified disease risk groups. As you all know, this is including intermediate to high risk. PT2 grade 4 or sarcomatoid PT3 of any grade, and then high risk PT4 or any T stage with positive lymph nodes, and even M1 that were made NED after resection of oligometastatic disease within less than 1 year from nephrectomy. And as you can see, there's a continuum of benefit and actually a gradient of benefit, starting with intermediate to high, which is higher in high-risk patients and actually even greater in M1 NED patients, which derive the most of treatment benefit with pembrolizumab. What about biomarkers, which is the actual topic of this presentation? Well, we have to discriminate between prognostic and predictive, at least. And up to date, most markers stratify the risk for recurrence. Very few are investigated or even validated to predict benefit. So we all know that the clinical and pathological risk factors, including stage, grade, necrosis, or comatoid histology, are prognostic, and we have developed several over the years, several nomograms and prognostic tools like the Assure RCC prognostic nomogram or the Memorial Sloan Kettering risk of recurrence tool, which are all very easy to use and are available online. Leibovitz score as well, and several others. What we don't have is specific tissue biomarkers to help us select the treatments that we need to give to our patients. For example, if we try to extrapolate anything from the more advanced setting, PD-L1 has been investigated and has been included in many trials, mostly as an exploratory biomarker, but its expression has been variable and has not been found as a reproducible predictive biomarker. Also, in the adjuvant keynote trial that we just discussed, the CPS score of PD-L1 was essentially not as important because it was positive in the great majority, in 3 out of 4 patients of the trial, 75%. So it's not actually used to guide therapy. This is different from the negative trial, Checkmate 914, where a small minority of patients, only 15%, were PD-L1 positive, and you can see a small signal there, although it's a small number of patients, whereby immunotherapy seemed to make a difference in terms of disease-free survival for these patients. If we try to move on to genomics, there are several genes, particularly within the chromatin remodeling family, like PBRM1 or BAP1, that have been associated with prognosis, particularly with overall survival. You can see in the left-hand side panel the negative predictive value of BAP1 mutations with respect to overall survival in DCGA untreated patient data. And also in Emotion 151, the fact that PBRM alterations do not really make a difference with respect to treatment, but they're prognostic overall. Interestingly, in the phase 3 CLEAR study, also in the metastatic setting, objective response rate was higher with the lenva-pembro combination compared to sunitinib, regardless of the presence of deleterious mutations in these genes. Another very important aspect of markers is gene expression signatures, for example, angiogenesis signatures or T-cell effector signatures that have been used to segregate renal tumors into molecular groups. And it seems like this is a schematic from the very, very important paper of Moser and co-workers published in Cancer Cell in 2020, essentially showing that there are 7 different molecular subtypes, and depending on the subtype, there's potentially different prognostic implications and potential benefit from atezo-bevacizumab combination compared to sunitinib. For example, the angiogenic and stromal signature tumors benefit from both treatments, as opposed to the T effector proliferative, which benefit basically from the immunotherapy plus TKI combination. To compare indirectly, this was also not important in the phase 3 CLEAR trial, also in the metastatic setting. So gene signature scores were not associated with progression-free survival in the Lenva-Pembro arm. And of course, sarcomadoid differentiation or histology is associated with poor prognosis. There's some evidence, exploratory, of course, of greater activity in these tumors, also associated with higher PD-L1 expression, for example, in the atezolizumab-bevacizumab combination. However, these are all hypothesis generating and have not been validated. So moving back to the adjuvant or preoperative setting, you can see that there's really no established biomarker, definitely not in the approved therapy, which is pembrolizumab, as a result of the Keynote 564 trial. And in all the other trials that were discussed, there's some novel biomarkers that we're going to discuss in the next few slides that are maybe promising. In the Emotion 010 trial, which was negative, this is a schematic of the biomarker collection schedule. So the patients had pretreatment tumor assessment with RNA sequencing, and also there was serum collection cycle 1, day 1, and also cycle 4, day 1, and also at discontinuation and also at disease recurrence, which was also the case for repeat RNA sequencing. Interestingly, KIM1, which is kidney injury molecule 1, stood out as the most significantly enriched circulating protein in recurrent samples compared to baseline. And that triggered the investigators' attention. And it seems like a higher baseline KIM1 level was also prognostic and associated with worse survival. That was significant as opposed to other potential biomarkers, including PD-L1 or like gene signatures, which were not significantly different between the two groups treatment with adjuvant atezolizumab versus placebo. So here you can also find a predictive, potential predictive value of baseline KIM1. They set the cutoff around the 60th percentile, which was at this point where the highest magnitude of significance was found. Interestingly, not just high baseline, but also no increase, at least above 30% during treatment or placebo, was also predictive of atezolizumab benefit. So as you can see in the right-hand side panel. So overall, what can we say about KIM1? Higher baseline is associated with worse prognosis, and the trial suggested some potential interaction with benefit from atezolizumab in the high KIM1 cohort, but this is hypothesis generating, and there's a long way to go ahead, including assay standardization and whether clinically meaningful cutoffs should be established to better investigate and assess KIM1 as a robust biomarker in the adjuvant setting. My group looked at this from another point of view, and based on TCGA data, there actually seems to be a direct association between high gene expression of KIM1, corresponding gene is HAV-CR1, and CD8 T cell, CD8 and CD4 T cell infiltration, as well as CD274 expression, which is encoding for PD-L1 protein. Moving on, another very important and potentially promising biomarker that has been emerging recently is the circulating tumor DNA status and its dynamics. You can see here data from the metastatic setting, a multi-center retrospective study with a short median follow-up of 10 months, relatively small number of patients, but you can see that serial negativity for ctDNA predicts for a longer progression-free survival as opposed to either persistent cDNA positivity or redetection at any point. In the adjuvant actually setting, or at least in the postoperative, pre and postoperative setting, there's one study I was able to detect with a very small number of patients. However, it's interesting that ctDNA positivity, both in the pre and postoperative settings, are associated with attenuated recurrence-free and overall survival. So overall, minimal residual disease through ctDNA may emerge as an important biomarker in the future. It is actually detectable in a subset of patients because in the real world, we lack enough sensitivity and there may be low levels of shedding in the adjuvant setting overall. So we may be unable to detect its levels. Additionally, preoperative trials need to incorporate ctDNA so that we're able to apply escalation and de-escalation concepts, like in the example of urothelial cancer, which really ctDNA has worked really well. And currently, its use is investigational, but it is increasingly used in trial design. Overall, the practical approach in 2025 and potentially 2026, I would suggest offer adjuvant pembrolizumab to eligible patients as per Keynote 564 criteria. We need, as doctors, to discuss the uncertainties with our patients. The absolute benefit may vary depending on the magnitude of the risk. There's important side effects from immunotherapy, and there's lack of validated predictive biomarkers so far. The use of ctDNA MRD testing should be restrained till present to research protocols that will allow us to refine risk and potentially guide future trial design. And overall, it has to be a multidisciplinary decision-making approach with also taking into account patient preferences. Overall, takeaway, adjuvant pembrolizumab improves DFS and OS, whereas other phase 3 trials of immunotherapy have been negative until today. There's no single validated tissue biomarker to predict adjuvant benefit from immunotherapy, and PD-L1 has not been reliable so far. Circulating biomarkers may be promising. KIM-1 is prognostic and could be predictive in select analysis, but we need to validate this prospectively. Tumor-informed ctDNA shows prognostic value, and trials are actually currently exploring ctDNA-guided adjuvant strategies. And look into the future, it is likely that we will have to integrate clinical pathological risk tools, minimal residual disease, plus solid biomarkers to make the best selection for our patients. Thank you very much for your attention.
Thank you very much. Dr. Brown, you will be the... Sorry for the technical problems, Dr. Brown. You will be the next. Please welcome Dr. Brown, Assistant Professor of Medicine at Yale School of Medicine. We will share your screen in a minute and we can start.
Okay, welcome everyone. I'm going to bring up my slides and then I think we'll get started. Let me do that now. Perfect. Are you able to see this okay? Okay. Well, thank you, everyone, and very excited to be here at this OncoDaily event and speaking about evolution of biomarkers in the frontline setting. I'm David Braun. I am a medical oncologist specializing in kidney cancer and run a research laboratory focused on the immunobiology of kidney cancer as well. So the first question is, why do we need biomarkers in RCC? And I think the other speakers have probably covered this fairly well, but I just want to highlight that if this was probably 10 years ago, we wouldn't need to talk about biomarkers because there were substantially fewer options that were available for our patients. But there's been an explosion over the last 7 to 10 years with Checkmate 214 in the frontline setting, multiple IO-TKI regimens in the frontline setting, and now, as the previous speaker had mentioned, with Keynote 564 with adjuvant pembrolizumab. But with this wealth of opportunity and many options, certainly comes many questions as well. Which therapy should my patient get in that frontline setting? ICI plus ICI or TKI-based regimen? What is the chance an individual treatment will work for an individual patient? In the adjuvant setting, whether a patient actually needs adjuvant therapy or not. And then while all of these have focused on efficacy, certainly toxicity is a major concern as well. And what is the likelihood of my patient getting toxicities from these therapies? And I think biomarkers at least have the potential to give us insight into all of these questions and really inform clinical decision-making for both patients and their physicians. And so why do we need to study biomarkers in kidney cancer specifically? There's lots of biomarkers for lung cancer and melanoma and other types. Why can't we just extrapolate to kidney cancer? And so I just want to briefly highlight that kidney cancer really is biologically distinct from other immunotherapy responsive cancer types. So one example of that is if we take all of our cancer types and arrange them from lowest total mutation burden, lowest TMB on the left, all the way to highest TMB on the right, we see that most of our immune therapy responsive tumors are all the way on the right. Melanoma and lung cancer and bladder cancer, very high mutation burden. And then kidney cancer is right in the middle. It's much more similar to ovarian cancer or pancreatic cancer or breast cancer. And those are ones we don't typically think of as necessarily being associated with immune checkpoint inhibitors. And so it sort of highlights that kidney cancer really is an outlier. And so to understand why biologically a certain therapy would work or not, to establish biomarkers, we really have to study it in a kidney cancer specific context. This is also highlighted by the fact that it has a different relationship with the immune system than other solid tumors. In almost every solid tumor, historically having a lot of CD8 T cells in that microenvironment is associated with a better prognosis. Those are highlighted by all of these green circles shown on the right of the screen. And the one notable exception, the one red circle there is renal cell carcinoma. Now, this is, again, evolving and it's a little bit different in the checkpoint era, but at least historically, having a ton of CD8 T cells in that tumor microenvironment was associated with a worse prognosis. This really highlights on that we need biomarkers, but we really need to study it in a kidney cancer specific way. Now, it's impossible to go over all of biomarkers, even frontline biomarkers, in just a short amount of time. But what I want to do is provide a little bit of a framework for how to think about at least current biomarker approaches. And if we have time, we might do a little bit of a whirlwind tour through some emerging approaches as well. So the first is just looking at the tissue, basic histology. And I would argue that actually, in terms of clinically actionable things, this is probably at the top of the list. This probably gives us the most information about when to use immune therapy. Next is getting a little bit more detail about that tumor microenvironment through spatial phenotyping, really understanding the composition of cells in the microenvironment. Moving on to next generation sequencing approaches, we can do understand the somatic alterations within the tumor, or even germline alterations that might impact response or likelihood of toxicity. We can look at gene expression of the tumor cells in the microenvironment to try to classify our tumors. We can look at circulating factors and particularly highlight KIM1, which I think is probably the most exciting biomarker that's been emerging within kidney cancer. And finally, moving to systems-wide, we really can are at the beginning of what I hope will be a molecular imaging era. And so what I'll do is briefly step through each of these categories, just highlighting maybe one or two examples of how these are being evaluated within kidney cancer and what some of those results have been. So starting with histology. Now, I would argue that this is probably the most important thing today, that we know, obviously, clear cell versus other histologic types, but within clear cell, having sarcomatoid and I think rhabdoid features as well is really a predictor of outcomes with immune therapy. So this is a reanalysis of the Checkmate 214 data led by Dr. Tanier from the MD Anderson, focusing only on those patients who had sarcomatoid histology. And we see, looking at the progression-free survival, that a pretty astonishing about 50% of patients had ongoing PFS, progression-free survival, at an extended time point in those patients who had sarcomatoid histology. If we look at responses, those patients with sarcomatoid histology had nearly 60% response rates and a nearly 20% complete response rate. So really, the patients who in some ways did the best were those patients with sarcomatoid histology. We've looked at this in our own cohorts back when I was at Dana-Farber, led by Ziad Bakouni, who's now at Sloan Kettering, and together with colleagues in the IMDC cohort as well. And in the real world setting, this absolutely holds up. Those patients with sarcomatoid or rhabdoid histology have superior survival with immune checkpoint inhibitors. And in work led by Chris Labaki, he's looked at this in the non-clear setting as well. This was presented at ASCO a couple of years ago. And again, in the non-clear setting, those patients with sarcomatoid or rhabdoid histology do substantially better when they're treated with immune checkpoint inhibitors. So histology matters. Sarcomatoid or rhabdoid really is a predictor of response to immune checkpoint inhibition. What about the composition of cells? And we think absolutely that makes a difference. There's been a ton of work on this. And I really want to highlight some of the work done by Dr. Spina Signoretti at the Brigham and Women's Hospital, who's really one of the leading translational pathologists who's investigated the particular immune types within the microenvironment. And what she's looked at is not just tumor cell PD-L1, though that probably has some role, but she's looked at the T cells that recognize those tumors, particularly CD8 T cells. And she defined a population that we'll call antigen experienced, but not terminally exhausted. They basically express PD-1, so they've seen an antigen, but they don't express TIM3 or LAG3. So they don't express co-inhibitory checkpoints, so they're not this terminally exhausted phenotype. And where those are at high levels, those patients treated with immune therapy in the green line did substantially better. So that's certainly a positive factor, having a lot of the right type of CD8 T cells. But having the wrong type of immune cell can be detrimental. And she focused particularly on PD-1 positive Tregs, because we think of anti-PD-1 therapy as sort of unleashing CD8 T cells, but they have the potential to unleash Tregs as well, particularly these PD-1 positive Tregs. And what she found was that those patients who had high levels of PD-1 positive Tregs in the tumor microenvironment did substantially worse with immune checkpoint inhibitors. And so she sort of put forward this model where it's really a balance. If you have more of these right CD8 T cells, these antigen experienced but not terminally exhausted T cells, and fewer of the Tregs, PD-1 positive Tregs, you'll do better. And if the balance shifts, those patients, unfortunately, are less likely to do well, at least with anti-PD-1 therapy by itself, and might need another modality such as a Treg depleting agent. Moving on to next generation sequencing approaches, I think this has really been a challenge in kidney cancer is the real answer. I think starting off, a lot of us were hoping we'd find the sort of equivalent of the EGFR mutation in lung cancer, something that well predicts whether a patient will respond to treatment or not. But kidney cancer is really a different beast. And I think that's highlighted here. This is work from our group, but many others have shown this as well, that shows that unlike in melanoma and lung cancer and other tumor types, TMB really does not predict for response to therapy in kidney cancer. Those patients with clinical benefit have no higher TMB, and high TMB doesn't predict for better progression-free or overall survival with anti-PD-1 therapy. But it's not that mutations are insignificant. It's particularly the right type of mutation. So if a mutation is present in every cell, clonal mutation, and it's one that leads to an immune target, if it forms a neoantigen, that has the potential to be helpful. And so we've looked at this. This was recently work from our group, led by Tejas Jamihal and Renee Salabi, together with Sachet Shukla and Tony Shwari and many others, where we focus particularly on exceptional responders. In this case, I'm showing data from the Checkmate 214 cohort, looking at patients who had deep and durable responses lasting years. And those patients with exceptional responses, not just the regular responses, but exceptional responses, had substantially more of these clonal neoantigens. So neoantigens and mutations certainly do play a role. But I think the reason why we're not finding our equivalent of the EGFR is that kidney cancer is very complex. And that's going to require not just looking at one feature at a time, but multiple features together. And I'll highlight one example of that from our own group, where we've looked at the Checkmate 025 trial, an initial pivotal phase 3 of anti-PD-1 therapy. And to summarize a lot of data, what we found was that contrary to what we'd sort of naively think going in, that tumors with lots of T cell infiltration would respond well to anti-PD-1 therapy, and those that have no T cells would respond poorly. What we found was there was really an interplay between the genetics of the tumor and the T cells. Those poorly infiltrated tumors were really enriched for these clinically favorable mutations in PBRM1, and those highly T cell infiltrated tumors were enriched for these clinically unfavorable deletions of 9p to 1.3. And so this is just one example that there's a lot of complexity, that looking at just one factor like just the genetics or just the immune phenotype at a time is probably going to be insufficient. We really have to look at these things together. I'll quickly highlight that these are all somatic alterations I've talked about, so think mutations in the tumor, but the germline also plays a role. This is work led by Mary Carrington's group, Dr. Mary Carrington's group, looking at HLA allelotypes, and particularly HLA A03. Those patients who don't have A03, shown in red and blue here, had good responses. This is in the checkmate cohorts as well, the patients treated with nivolumab. Those who were heterozygous maybe did slightly worse. They had a higher progressive disease rate. But then those patients who are homozygous for HLA-A03 had zero responses to treatment. And so again, highlighting that germline genetics might play a role, certainly in response to therapy, but also potentially in toxicity. This is work led by Sasha Gusev's group, which showed that across multiple cohorts, having a germline variant in IL-7, a reasonably common germline variant in IL-7, was substantially associated with an increased risks of immune-related adverse events. So really the power of genetic features to not just predict response, but also potentially toxicity. When we think of next generation sequencing, it's not just at the DNA or genomic level, it's also the RNA level. What are the gene expression patterns? And this can really play a role in response and resistance. I'll highlight maybe two brief examples in this. The first are endogenous retroviruses. These are fragments of old retroviruses that incorporate into all of our genomes. It's in all of our DNA, incorporated tens or hundreds of millions of years ago, but are usually dormant. They're usually silent. But in cancer, they can become reawakened, and particularly within kidney cancer. And when they do, we think that might actually be an immune target. And multiple groups have shown, this is work led by Christoph Smith, Ben Vincent's group, showed that anti-PD-1s were enriched for expression of this particular ERV in the tumor, HER4700. Kim Rathmel's group has shown that another ERV, ERV 3.2, is enriched in anti-PD-1 responsive tumors. Again, this is tumor cell expression. Sabina Signoretti's group has looked at ERV E4, ERV originally defined by Richard Child's group to play an important role in kidney cancer. Again, increased expression of that ERV in a tumor was associated with better outcomes with anti-PD-1 therapy. And in collaborative work led by Qinqin Zhang, the very talented postdoc in Bill Kalin's group, we're able to show that there's actually a set of ERVs that are directly regulated by HIF that become antigens and are potentially antigens in the context of immunotherapy. So I think ERVs are really going to be in an emerging area of exploration for biomarkers in the future. But I think the strongest work in this group was done by Dr. Brian Rini, Bob Motzer, the Genentech group, which is a post-hoc analysis of the Emotion 151 trial. Really, I think a beautiful demonstration of how we can learn biologically from a clinical trial that was ultimately had a negative clinical endpoint, but still incredibly valuable for the field. And what they did was look at RNA sequencing transcriptomic data from those over 800 patient tumors. And what they defined were 7 molecular subtypes, these 7 molecular clusters here. There were ones that were associated more with angiogenesis, like clusters 1 and 2, and ones associated more with cell cycling or an immune profile, a T effector program, and that's clusters 4 and 5. And remarkably, what they found was that these molecular subtypes, these transcriptomically defined molecular subtypes, really played an important role in response and survival. That those with the angiogenic subtype, actually reverse, those with the immune subtype, 4 and 5, or proliferative subtype, seem like they did substantially better with immunotherapy, with atezolizumab-based therapy. And those with angiogenic subtype did just fine with sunitinib alone. So this is really sort of an important finding, but I think with any biomarker, it's important to really see, is this only true in this particular context with this therapy, or is this really a broader phenomenon? So our group, this is work again led by Renee Salaby, Chris Labaki, others, has looked at this in an additional trial set. So again, we re-looked at this in Emotion 151 and found the same thing, that those patients with angiogenic tumors actually did just fine with sunitinib alone. But when we applied it to a FDA-approved regimen, Javelin Renal 101, we found that actually in this context, even in subtypes 1 and 2, the IO-based combination, avelumab plus axitinib, did substantially better, both in terms of response and in terms of progression-free survival across all subtypes, but including across angiogenic subtypes. So this really highlights to me that we really need it's important to define biomarkers, and that's done retrospectively, but then you really need to test this in additional cohorts and ultimately, ideally, test it prospectively. And that's what the group led by Dr. Rini is doing, in what I think is a really important proof of concept study, that you can actually have a biomarker-directed trial based on this molecular subtyping is actually trying to prospectively divide patients into clusters 1 and 2, angiogenic or immune proliferative, and give them different therapies based on their molecular subtype. So moving on from DNA to RNA now to protein, I think we enter what is sort of the most promising biomarker that's emerging, and that's KIM1. And we heard a little bit about it in our prior talk. It's a kidney injury molecule 1. It's overexpressed in kidney cancer and papillary, not in healthy kidneys. It is expressed in kidney injury, where the name comes from, but much higher levels in cancer. And it can be cleaved and then detectable in urine and plasma. Really, this work has by and large been led by Vincent Hsu at Dana-Farber, and I credit him for some of these slides as well, but really also for really lifting this field forward. And what he's shown is that it can be elevated even prior to diagnosis, circulating KIM1. It can be in the adjuvant setting, a marker of risk. And then in the metastatic setting, certainly can be associated with outcomes, and we'll see that here. I'll step through this very quickly because our previous speaker mentioned in the adjuvant setting, KIM1 is prognostic, so high KIM1 is a worse thing, but it's also predictive that in high KIM1 patients, that's where adjuvant atezolizumab showed benefit, where it didn't show benefit in the KIM1 low or the overall population. So this is really promising in terms of a potential biomarker, but in the metastatic setting, it has a role as well. So this is, again, work led by Vincent Hsu. And so what they did was, part of the Checkmate 214 trial, they had plasma samples prior to treatment and before cycle 2, so right at 3 weeks, and looked at the ratio. Did KIM1 increase or decrease, and if so, by how much? And what they found was really a remarkable pattern. Those patients that had a substantial decrease in their KIM1 on treatment had much better responses, but you can see this incredible progression-free survival rate, a PFS of, if my math is right, almost 6 years. And you see that that's the best case scenario, 30% decrease of KIM1 or more. But it really scales fairly linearly. That you can see if you don't have as much of a KIM1 decrease, you don't do quite as well. And if you're at the other extreme, you have a KIM1 increase of 30% or more, those patients do very poorly, very low response rates, and very low progression-free survival. And so this is true for Nivo plus Ipi, the immune therapy arm. This was not the case for sunitinib. So this is not just an overall marker of sort of tumor burden or response. And so this is really emerging, again, has to be tested now prospectively, emerging as a very, very promising biomarker. And finally, in terms of current approaches, molecular imaging has certainly become an exciting development with the Zircon study led by Dr. Brian Shuck. This was evaluating small renal masses in over 280 patients with this girentuximab antibody and anti-CA9 antibody conjugated to zirconium, had over 85% sensitivity and specificity for really defining renal masses. We can see this here where it's successfully able to define clear cell RCC in this small renal mass. But for another benign lesion, we can see that by the PET tracer, it is PET tracer negative. And so the hope is that this is going to emerge as sort of the kidney cancer equivalent of a PSMA PET scan. And so very briefly, I've mentioned the conventional approaches, but there's a whole host of emerging approaches as well, circulating epigenomic approaches, single cell, spatial phenotyping, and functional modeling. I won't go into too many details, but I'll highlight maybe just a couple of quick things. So beyond circulating tumor DNA, we can look at the circulating methylated DNA or the circulating histone profile, and those can provide rich information, led by Matt Freeman's group and Sylvan Baca and Tony Shueri. But I think we need to embrace the complexity and really understand these tumor microenvironments at a cellular level. I think a lot of what we've done so far in terms of biomarker development is sort of shown here. And this is particularly with genomic-based biomarkers. We're trying to take a patient who responds, a patient who doesn't respond, take their tumor microenvironment, which I've represented here by a fruit salad. So the tumor microenvironment are very heterogeneous. So each piece of fruit here represents a different cell within the tumor microenvironment. We have our kiwi cells, the tumor cells. We have our pineapple, the T cells. We have different cell types within the microenvironment. And what we typically do is take those fruit salads, those tumors, we put them into a blender for sequencing, and we get out something that looks like this, a fruit smoothie. And that is our conventional sequencing approach. And we look at these different smoothies and we say, maybe this one's more red than that one, so maybe that's why this tumor was resistant, that tumor's not. But if we could go back to the fruit salad and pick it out one by one, maybe we'd understand that the banana cell is the key to success and the grape cell is the key to resistance, really by understanding the individual components of the microenvironment. And that's what single cell sequencing enables us. And we've done some work in this space and certainly have understood how now tumors evolve, the immune system evolves as we progress through therapy. But even single cell sequencing gets us only so far. So if conventional sequencing is our smoothie, basically what single cell sequencing gives us is a parts list. It gives us what are the individual components of the tumor microenvironment, but it doesn't tell us how they're related to one another. It doesn't tell us the spatial orientation. And that's where really spatial profiling, spatial transcriptomics, and other approaches are emerging that really provides high dimensional data that allows us to really see a much fuller picture. And in work led by the Friedman group, they've begun to use this to understand how things like tertiary lymphoid structures, these lymphoid aggregates within the tumor, might be associated with improved outcomes. The last thing I'll briefly mention, I'm going to skip ahead, is we have all of these different data types, but I think the future lies in embracing complexity and bringing this all together, and that's going to require machine learning-based approaches. So in partnership with Bristol Myers, we've begun to do this. We presented this at ASCO this year. This is work done using some conventional biomarkers and some more emergent novel biomarkers, but we used a set of different types of biomarkers. This is for the Checkmate 9ER trial, and really combine them together using a machine learning-based approach. And what we found was that for sunitinib versus nivolumab plus cabozantinib, there were different features that were important. There were some things that were only important for the immune therapy, like the proportion of plasma cells in the stroma. There were other things that were more important for sunitinib, and there are things that had opposing effects. But ultimately, these integrative machine learning models really were able to outperform univariate analysis by a substantial amount. And so really highlighting to us that integrating these data using AI-based approaches is going to be important. And so this was a little bit of a whirlwind introduction to biomarkers, but I think where we're moving in the future is really these high dimensional assays, embracing the complexity. I skipped over it, but not only taking static views, but actually taking living tumor pieces and evaluating them, living biomarkers, but also leveraging AI technologies to really integrate these together. And I think our grounding force here really should be the biology of the tumor. We have to really understand the biology of kidney cancer. And by doing that, that's ultimately going to lead to better biomarkers. So with that, lots of people to thank, the patients and their family who make all of this biomarker work possible, all of the organizers for this, and then for the work that I've shown in our lab, just my lab members, they're shown here. They're really the ones who do all the work, and they're smart ones. I just get to speak to you all, and always happy to chat with anyone if there's any questions or opportunities for collaboration. Thanks so much.
Thank you, Dr. Brown, for your remarkable presentation, and you have dived us into the frontline therapies and how to guide the treatment. And now we're moving, thanks for excellent presentation. We're now going to discuss a bit more on the bedside, and we'll see how these novel therapies work and how to mitigate the toxicities. So the next speaker will be Dr. Rana McKay, who will be speaking about management of IO and TKI toxicities. And she is the adult nurse practitioner at UC San Diego Health. Dr. Rana, can you hear us?
Yes, hi. Thank you so much for having me.
Hello. So I'll be leaving you once your presentation is okay.
That sounds
Please,
great.
Can our team share the presentation?
I'm happy to share my screen too. 1 second. Oh, okay. Perfect. All right, wonderful. Thank you all so much for having me today. I'm thrilled to be here with you. So my name is Archana Ajmer. I'm a nurse practitioner from UC San Diego. And we're going to talk a little bit more about practical approaches to management of IO and TKI toxicity. Next slide. Next slide. Yeah, thank you. So our objectives today, briefly, we'll talk about just the evolution of treatment of kidney cancer. We heard an amazing lecture about where we are now, but it's really incredible when we get a chance to look back. Next, we'll just review some of the classes of drugs and mechanism of action, and then we'll talk a bit more about toxicity, specifically of immunotherapy and VEGF TKI, and then I'll leave you with some tools and resources to talk with your patients. Next slide. So this is just a landscape for you to see the evolution of systemic therapy for kidney cancer. You know, in 1992, we really only had one therapy. It was the cytokine era. And since then, we've really evolved tremendously to all of the different therapies, not only single agent monotherapy with TKI and immunotherapy, but now combination therapy with IO. And then most recently, you know, with the approval of our HIF-2 alpha inhibitor. So it's really pretty amazing to see sort of the trajectory of work that's happened, all of the, you know, critical trials that have gotten to the approval of these drugs, and that we're keeping our patients alive a lot longer than we used to be able to with all of these options. Next slide. So we'll start by talking about immunotherapy specifically. This is just sort of a list of all the different drug classes from the previous slide, but we're going to focus our attention on the top two. Next slide. And so this is likely review for most, but just to remind everyone, you know, that cancer cells really are able to avoid detection by the body's T cells. Next slide. And so immunotherapy works by taking the brakes off of this, right? So checkpoint inhibitors are these drugs that work by breaking that connection between the checkpoint proteins, and therefore it increases immune activation so that it can go after these cancer cells. Next slide. So toxicity profile for immunotherapy is really very different than what traditionally we thought about, you know, years ago with chemotherapy. And so some of the critical elements when we talk with our patients and sort of in the clinic itself is identifying these toxicities early and recognizing and educating our patients that these can occur at any time. I really like this graphic. Oftentimes I'll talk to patients and show them a graphic like this so they can get a visual of how the immunotherapy can really impact any organ system. But then we really focus a lot of our attention and conversation in the clinic about some of our most common toxicities listed here. And we'll go into that a little bit more detail. Next slide. So timing of side effects is one of the critical components of education for patients. Timing onset obviously varies depending on whether it's depending on the type of toxicity we're talking about. But the first most common toxicity we tend to see is the skin toxicity, and that can occur as early as after the first cycle. Many of the toxicities that we see can occur after cycles 2 or 3, but this graphic really depicts that well. Next slide. So I often will talk to patients a lot about this, who to call, when to call, understanding the timing around the toxicities, and the importance of evaluation by the team, as well as making sure that we rule out other causes and treat as soon as we can. Next slide. There are special populations. So anytime we think about, you know, who is a good candidate for immunotherapy, we're thinking about and ruling out, higher risk individuals. But this is just a brief list, you know, patients who have a history of autoimmune disorders or a history of IRAs previously, a transplant population, patients who have poor liver, kidney, liver, cardiac function, chronic viral infections. These aren't necessarily contraindications, but it definitely requires some shared decision-making with these patients, collaboration with subspecialty care, and ensuring that it's safe for this patient. They understand the risks. Next slide. This is probably review again for most, but CTCA grading criteria is our standard tool that we use to grade side effects, both in oncology clinical trials, but also in clinical practice. And so I'll reference this moving forward. But anytime we're talking with patients, this is really the tool that we use when we educate our nursing team as they triage patients on the phone. How severe is your symptom? Because that really will guide our treatment. Next slide. So we'll start by talking about dermatologic toxicities. So this is really, as we mentioned earlier, the most prevalent of our IRAEs. This is an inflammatory skin reaction that often occurs within the first or second cycle of treatment. Many patients will complain after just one dose that they start to experience itching or pruritus. The incidence range really varies. It can be as high as 45%, half of patients who get ipilimumab. It can be around 34% for PD-L1 or PD-1 inhibitors as monotherapy, but it typically presents on the truncal areas as a maculopapular rash, sometimes can form plaques. And grade 3 and 4 toxicities are rare, but when they are severe to that degree, we often don't retreat. Next slide. This is just a depiction of kind of a common rash, but management often is topical oral antihistamines, topical steroids, emollients. We will sometimes use Atarax just for symptomatic relief. But when it's really severe, that's when we turn to oral steroids. Many of these patients are able to do just fine with topicals and oral antihistamines and treat right through these rashes. But for some, it can be quite irritating.